So thank you for allowing me to present my study on the relationship of MRI small bowel dysmotility and patient symptoms. We're looking at automated versus subjective assessment. The purpose of our study was to assess the association between small bowel motility patterns and abdominal symptoms in Crohn's disease patients. The motility patterns were analysed using cine MRI data, which is where a series of imagers acquired over a short period of time can then be played back as a movie. And symptoms were recorded using a patient questionnaire called the Harvey-Bradshaw Index. Furthermore, we wanted to compare the performance of a subjective model with radiologist-based grading of motility and test that against symptoms, and then a more automated model with the equivalent image motility metrics against symptoms. So I'm going to show a few examples of cine MRI images. This is a good example of spatial variation in motility. As you can see, there are two areas of active motility, but there are also some areas of inactive motility. So spatial variation is very high in this example. It's also more consistent motility. This is a more homogeneous example, which is just highly active as the small bowel is moving throughout. And there's also inactive, where there's no movement at all. So clinically, a radiologist use these images to visually assess specific regions for the absence or presence of motility. So if motility is present, they can be reassured that everything appears to be okay. But if it's absent, it requires further investigation. However, it's quite difficult to visualize globally due to all the interactions between different regions. So therefore, we wanted to have something that was more objective. Therefore, this Motility Map technique, which is an image registration-based technique, was developed to take the motility seen in the cine MRI image and make a quantitative, objective motility map, where each pixel in the map has a motility score associated, ranging from low motility in blue and high motility in red. So you can see in this image that there's a lot of movement in the middle, and this is represented on the motility map. So, what can we use motility for as a biomarker? Well, a previous study has shown terminal ileum motility negatively correlates with disease activity. So in the left-hand image, the terminal ileum is not moving at all, and it's a disease example, an inflamed terminal ileum, and in the right-hand image, there's a loss of motility in the terminal ileum. However, this is just in a specific region, and we wanted to look more globally throughout the whole small bowel, and we wanted to look at the relationship with symptoms. So the motivation for the study came from an IBD study from Menace et al., where there were generally two examples of patients with high spatial variation in the left-hand image. As you can see, in the left-hand part of the small bowel ROI, there's a lot of motility occurring, and in the right-hand side, there is no motility. And patients with this seem to be more asymptomatic, and then in the right-hand image is a more symptomatic patient, which had consistent motility rate, so low spatial variation. So in this study, they from the motility map, took a spatial variation motility metric, tested against HBI, which had components such as general well-being, pain, and diarrhea, and then found that this spatial variation motility metric negatively correlated with symptoms. So we wanted to build on this previous work by including subjective radiologist scoring, introduce more computer-based metrics, and previously, since it was one metric tested against HBI, we wanted to test all these new metrics in combination, see if a combination of factors relates to symptoms. So we had 114 Crohn's disease patients in a two-centre study with cine motility MRI acquired with 20-second breath hold and mannitol preparation, and a Harvey-Bradshaw Index questionnaire was completed the day before scanning. So we got a radiologist with over 10 years experience in GI imaging to view images such as this for 5 features of mean motility, spatial variation, temporal variation, area active and distension. Temporal variation. So low temporal variation would be if a specific area is consistent throughout the entire 20-second scan. So if it is active throughout the entire time, it's low temporal variation. If it's inactive for the entire time, also low temporal variation. Whereas if it's switched on and off, then this is high temporal variation. Area active is simply the percentage of estimation of the percentage of pixels that are active throughout the whole small bowel ROI. And distension is based on the brightness and the diameter of the small bowel lumen. So good distension is a very bright lumen with a wide diameter. I then developed computer-based metrics which were meant to represent what the radiologist was visually scoring in a more objective manner. And then this allowed us to have two models, a subjective model with all these features, which we could then test against symptoms, and then a more objective model with all these features to again test against symptoms. So what we found was the radiologist-based scores had no correlation with HBI, so we couldn't create a predictive HBI model, whereas with the objective model, two of the computer-based metrics in combination could create an HBI model, and these were spatial variation and area active. So when we plugged the data back into our model and then tested against the actual HBI, we found a Pearson correlation of 0.29, which was significant. So it's not the best, but the point here is that it's an improvement on subjective scoring. So, in summary, the link between motility patterns and symptoms is a potential biomarker. This is a significant but weak combination, correlation between computer-based metrics and HBI, although these metrics are an improvement on visual scoring. The limitation with this study is it's not easy to capture symptoms due to HBI being mostly subjective, and cine MRI motility scans may need to be longer, because 20 seconds may not be long enough to see the motility patterns we're looking for, and the preparation might not be the best. Mannitol is known to induce motility, whereas we may need to do a calorie drink alternative, which may give a more natural motility patterns. So I'd just like to acknowledge all my co-authors, and thank you for your attention.